We'd really like to get started, and I'm sure you'd like to get started as well. So I'm going to introduce the guests, ladies first. We have Dr. Padre Ots from Alicante in Spain, Ahmed Asaf from Egypt, and Bobby Ang from the Philippines. We're all good friends here. We're loyal supporters of BVI. They're people, as you already know, and they have great products, as you'll find out. So without much ado, I'd like to ask Bobby Ang to get started, and he's going to talk about the Fine Vision and the Fine Vision HP and his experience, good experience, over the years. Bobby.
Good evening, everybody, and thank you for having us here to share our experience with the Fine Vision trifocal lenses. So here is my talk. We did this study a couple of years ago wherein we compared the Fine Vision hydrophilic versus the Fine Vision hydrophobic. So it's same optical technology but different material. And so we go back to some basics of trifocal technology. So two features that the trifocal Fine Vision has is convolution and apodization. I know that some companies prefer apodization, some companies prefer non-apodization. It's basically, there's no right and wrong. It's basically a strategy of maximizing light energy to go in the eye. So as you know, apodization means if you are looking at near and your pupil goes small, you want more light energy for near. And when you're looking at distance, when the pupil dilates, you have more energy for distance. The convolution part is the smoothing of the edges. You want more smooth edges of the diffractive rings so that there's no light scatter. So when light goes through a medium, you want as little rough edges to scatter the image. So the Fine Vision trifocal family has these two unique combined procedures which basically the other companies are starting to copy or something, which is a flattering thing. If you're the best, then people want to copy. So, as again, pupil dynamics, you see that when you look at distance, basically the accommodative mechanism is your pupil grows larger, so more light energy is devoted to distance, versus when you read a book or you look at your cell phone, your pupil goes smaller, so you want more light energy for near. And that's the advantage of apodization. So, we are comparing two trifocal toric lenses. The Pod F is the predicate hydrophilic lens, and the Pod FGF, we called it Pod FGF during the study because GF stands for glistening free, but I think the commercial model is called HP, no? So HP, so the water content is more in the hydrophilic, but the refractive index is higher, meaning there's more better contrast, AB numbers higher with the hydrophilic also. So there is a little bit of advantage in one side versus the hydrophobic, which means that people feel that there's less PCO formation. So there's a little bit of advantage on one side being hydrophilic. There's a little bit of advantage in the other side being hydrophobic. The more important thing is Fine Vision or BVI is the only company that gives you the same optic with different material. If you go to other brands, you're either committed to hydrophobic only or hydrophilic only. This one, if you trust the optics, then it's up to you to choose the material that you want. So we've done several papers, and our latest paper was lately published on the 2-year outcomes of the hydrophilic versus the hydrophobic just this year. So in this study, we wanted to see. So first is I used different A constants because, as you know, the material affects the A constant. So I use my personalized A constant, and as you can see, the refractive outcomes are very similar. So I'm almost near plus minus 0.25 in almost all eyes, and MRSE all the way up to 3 years. So you see, we followed the patients 2 years, 3 years down the line, and even cylinder and sphere and spherical equivalent are more or less stable. So the lens does not move with capsular contraction, and you see a shift in the sphere or a tilt which induces cylinder. So both hydrophilic and hydrophobic models are very stable in terms of refractive outcomes. And as you all know, if you use a presbyopia correcting lens, you will enjoy the best outcomes if you're on target. If you're off target, plus 0.75 or minus a half, all bets are off. All vision is bad. So you want to be within 0.5 or 0.25 as much as possible. And as you can see, uncorrected distance, uncorrected intermediate and near is less than 0.1 in all visual distances. So you're more or less enjoying very similar, not statistically significant difference in uncorrected vision. So I always choose uncorrected. We want to present best corrected, but that's not what the patient sees. The patient sees uncorrected vision. So we also check the focus curves at 12 months and 24 months. You can see that it's typical. The trifocal in bench is 3 humps, but in reality, they see the smooth, gradual sloping down, and the wider the defocus is, the more the patient enjoys the vision. So the trifocals, as you can see in both models, are enjoying a wide range of near vision. And even the near vision is not decreasing. So this is the difference between a trifocal and an EDOF. If you use an EDOF, this will drop straight down. So the trifocal, you see a little bit of more near vision than intermediate. Contrast sensitivity. So actually, I think over the past 8 to 10 years, the trifocal technology has actually saved us because contrast vision is good, whatever brand you choose. The trifocal technology has really increased or maintained good contrast over time. So with both hydrophilic and hydrophobic models, there's no difference in contrast. You're not losing contrast whichever material you choose. Now, questionnaire, you see that we ask the patient, because now it's very big and patient-reported outcomes. You have to ask the patient how happy they are. And as you can see, very, very few, if none, are not happy. Almost all patients are completely or very happy or satisfied with their vision, whether it's hydrophobic or hydrophilic. In this study, they're masked. They don't know if they received the hydrophilic or they don't receive the hydrophobic. So, in conclusion, after seeing the performance of this lens for the past 12 years or so, I see that the hydrophilic, I've been happy with it for 12 years. Then the hydrophobic is a new addition, and it actually performs as well. Now, you don't want one lens to outperform the other because of the material, then you have to select one. Both are performing as well because it's the optical properties that are performing, not the material. So the optical properties are solid. And because of that, all the publications reflect our clinical results, which means that whatever you see in the publication, you're not surprised that the patient's not seeing as good as what's in the publication. You see well, and now patients outside US can choose whatever material they want, hydrophilic or hydrophobic, whichever design you want, you will be satisfied with the vision, and your patients will be happy with the outcomes. Thank you very much.
Well, thank you. I suppose I need to announce myself in. Let me have that. Great, thank you very much, Bobby. We're going to have a discussion and some questions from the audience. There are some roving microphones, is that right? Are there any roving microphones? That's okay, we'll use them in a moment. So I'm going to talk about, so you've seen the evolution that's taken place from hydrophilic to hydrophobic, and I'm going to talk about the new hydrophobic toric lens that we've had experience with at our center in the United Kingdom. So you already heard this bit, so I'm not going to repeat it, about how the lens works by reducing halos and glare, and how it takes lost energy and actually uses it for near. That was very well instructed by Bob. Now the toric lens the toricity is on the back surface, and you can identify the axis, the plus axis, by those 3 dots on the lens there. So you orientate this lens in the plus axis of the corneal astigmatism. So we actually did a retrospective audit on our patients on 62 eyes. We looked at them at 6 weeks. 27 of them were bilateral, which is kind of useful information because they do get more mileage when they use both eyes than just one. We chose a spherical equivalent on the IOL masthead. Corneal topography, the axis and magnitude was evaluated using the S2 and S4 aberrations on the OPD3 and also the KR1W. I'll be talking about that in a moment. And he used the online calculator to calculate the lens implant using an A constant of 9.4. The eye was marked at the slit lamp, as you can see here. Eye mark on axis. A lot of people talk about marking at 3 and 9 and then going into the operating room with a Mendes marker and then reorientating. That doesn't make any sense to me because you're doing things twice. You've got 2 sets of error. I think it's always better to just mark directly on axis using the slit lamp, and then that keeps you away from trouble. We use a femtosecond laser in every single case and a 1.8 mm incision, and there was phacoemulsification using the Stellaris. So why do we use corneal aberrometry? Well, this is the OPD3 scan, and it's a printout that we created with them. It's got my name on it. But what we're looking at is these things. This is the corneal astigmatism. This shows the orientation of astigmatism. It also shows, it shows the axis and it shows the magnitude. And this is what we use to evaluate how much corneal astigmatism patients have, and also how to orientate the lens, because that's what we're treating, the corneal aberrations based on topography, to obtain an accurate result. And the good thing is we can also figure out what's going on inside the eye by looking at the internal aberrations, as you can see right here. So this is the lens going into the eye. I don't know if you can see it with this broad daylight, but it's a speeded up video. I'm not that rough a surgeon. And here I'm orientating the lens. You can see the axis marks that I put on that patient. And I do believe it's very important to get rid of all the viscoelastic behind the lens because you don't really want that lens to move with a cushion of viscoelastic. So we paid a lot of attention to doing that. And just make sure once all the irrigation aspiration is accomplished that the lens still has remained on axis. Sometimes people forget. So what were the outcomes like? Well, this is preoperatively. You've got the numbers there. In the spherical equivalent, notice we've got a refractive cylinder, which doesn't really matter. The keratometric cylinder is what we're treating. And if you look at the aberrometric cylinder, it's not too dissimilar. So these are the outcomes. So when you look at the pre-op values and the post-op values, it says 1 month. That's what the program does. It's 6 weeks. And you can see the predictability was very, very good. Within half an hour, not as good as Bobby Ang. He goes within a quarter of an hour, but 87% within half an hour, and every patient is within 1 hour. This is monocular and this is binocular, and you'd expect binocular to do very, very well. But actually, they did pretty well monocularly as well. This is vision, accumulative. And these are the sort of graphs that all the journals want you to start using. This is the uncorrected distance visual acuity. So at 6 weeks, 100% we're 6 at 7.5, 95% at 80% at 6.6. And there's near and intermediate at 60 and 80. So you've got 3 bars there, and the results basically speak for themselves. This is safety. There's a 7% had a reduction, and a lot of these patients would eventually need YAG capsulotomies. So we really would need to see them at 3 months after their YAGs to decide what their true outcome was. But you can see the gain in vision, and certainly unchanged in the laser lens replacement group. Astigmatism, this is predictability. You can see 85% within a quarter data. Now I'm getting to be like Bobby Ang's results here, right? And this is what's really important, is that, so we're looking at corneal astigmatism and refractive astigmatism postoperatively. The corneal astigmatism, as you see, doesn't change. But the refractive cylinder changes dramatically, and you get that little circle is incredibly reduced with a centroid of 0.07 diopters. I think that's pretty respectable for a lens like this. So how do we evaluate lens stability? Now, this is probably prone to errors, depending on the technician evaluating the patient and a dry eye, amongst other things. So we looked at the internal aberrations on the lens. So we know what the cornea is doing. We know what they're doing internally. Now remember, the wound is also healing, so that could change the axis a little bit. And this is subject to further analysis. But this gives you an idea as to why we would use this. So that's patients at 12 degrees, that's spot on. That's exactly where we want that lens to be. So we evaluated that, and we found that 61% were within 5 degrees, 18% were within 10 degrees, and 6 were outside that range. Now you think that if this is out, they would need an enhancement. Well, actually, we didn't enhance any patients. None were decentered. There were no interventions at all because their refractive outcomes were great, and the unaided vision was also very, very good. So the aberration is useful, but it's not 100% in terms of accuracy. So overall, we found that the fine vision pod toric, the giant leap in terms of toric lenses, gave really, really good outcomes, both in terms of spherical equivalent and astigmatism correction. The lenses are stable in terms of orientation. All our patients are spectacle-free, and it actually also works very well in post-corneal refractive surgery patients, which is a topic for another day. Patient satisfaction was very high. Thank you for your attention. Now, are there any questions from the audience before we go on to the next phase? Come on, there's got to be some burning questions there. Yes? Can you give me a microphone? Can we give him a... No, it's off. Yeah? Speak with a bit of...
Okay. So you mentioned corneal astigmatism. What you mean by it's a anterior total? Because what I could understand that
it's so the corneal astigmatism is based on corneal topography. It's corneal, the aberration S2, S4 is derived, like you do with the pentafan. So, the OPD3 does the
so
same
you don't
thing.
have a barometry. That I could understand. So what you do if you don't have a barometer?
Get one. The OPD3, you're a refractive surgeon.
Yeah.
It's your pocket.
So you will not
you
use...
put your hand in it, you take out your wallet, and you buy it.
What I mean is that
Yeah.
that you will use the total corneal power for calculating the astigmatism or not.
The top, what are you using? Some people use the IOL Master, which I think is a terrible idea.
Yeah.
There are some, like maybe the new IOL Masters with the TK or whatever they call it. That might be better. I don't know. I have no experience with it. You need to know the orientation and the magnitude. Would you agree?
Yeah.
So what are you going to measure? You're going to measure 3.2, 3.5, 4 millimeters, 5 millimeters?
But when the posterior have a discrepancy than the anterior, then what will do?
The posterior, I don't even bother looking at that. I think that's a lot of noise, a lot of fluff. It makes no sense. It makes sense, but it doesn't have any impact. So in this study, we didn't look at posterior corneal astigmatism.
Okay.
We just looked at anterior corneal astigmatism and treated that.
Well, luckily that you don't have any discrepancy between posterior and anterior.
You got the blood discrepancies?
Sure, we have. That's why.
Are you sure it's not because the axis was off?
The axis will be different, and from the anterior, when we have any discrepancy, so you need to go to look at the posterior.
The posterior
that's right. Barrett now.
It's so small.
Mathematic.
It's so small.
Anyway.
So, maybe 0.25 because it's inside the eye.
Sometimes it's not in this way, Shiraz.
Maybe in keratoconus, but not those. Yeah, Ahmed. Yeah, go on.
You go. I think we include the posterior corneal astigmatism with the Barrett's calculator, so it's okay. So we can
use the Barrett.
Yeah, we use the Barrett, so we can include the posterior corneal astigmatism, which is either measured or predicted. So if you don't have the barometer to measure the posterior corneal astigmatism, you can use the Barrett. It's okay with the predicted corneal astigmatism.
If you have a pentagram,
Yeah. Total K with predicted or measured. Yes, we can use it then predicted if you don't have.
Yeah. So there are many ways to skin a cat. Okay. This is my way. It works well for me. Any other comments or questions?
It's really, I have a question, but I have a question to Dr. Anna. But
Yes.
so, I come from Vietnam. I think we have the same situation in our country. So, when you talked about the fine vision and fine vision experience, so you say that it's maybe the same. We can say we can choose. We have a wide range of choice, but maybe you have a favorite. You have a group of favorite patients for fine vision, or fine vision happy for height or age or yes. So can you?
Actually, for our area,
Yes.
we have a lot of high myopes, long eyeballs.
Yeah.
So it makes targeting quite challenging. My nomogram, I've had like since Shiraz introduced me to the Fine Vision 12 years ago, I have a set nomogram which is more robust for the hydrophilic because we have been using hydrophilic for 12 years. So my favorite is still the hydrophilic. Honestly, my favorite is still for hydrophilic. But then we have happy patients. So, but if you, because of the preference in material, if you are using other brands and you want hydrophobic,
Yes.
you just get your A constant personalized. Then I think you will like both.
Oh, okay, but let's see. I used to use the High Vision. Maybe in the future, if we have the supply of High Vision HP in our country, maybe
Yeah.
I can choose it also. Oh, thank you. Very
But
much.
you've tried the hydrophilic.
Yes. Yeah.
Yeah, thank you.
Yeah.
So, yes, go ahead. Don't be cheeky.
Okay. You use for the calculation of the cylinder, you use topography. Okay, I have the Pentagon, but that is a Scheinflug system. Takes more time to measure. So we use the IOL Master 700. We think better results.
You think or you know?
Well, that's a good question, of course.
Sense?
I would like to.
Or science?
Yeah. Like
Okay.
the nose, yeah, true. So, what do you think Pentagon is better? Even,
I
you know,
I have another talk on that, which I could for another day, where we looked at both. But
yes.
I prefer speedy, good information, both external aberrations, corneal aberrations, and internal aberrations. I get a lot of information for one page on the OPD3. So, yeah, all of us, we have our preferences and our habits. That's my habit. But the Pentagram does work. It does provide you with S2, so you can eliminate all the other aberrations. Look at the S2, you can see the orientation, and you can also see the magnitude. So it's useful.
I think for me, I use the IL Master more. I have both, but we are the same. I use the IL Master because we already have our own toric formulas. I'm sure I don't know what you use, but I use the Barrett toric. I don't use the True K. No, because I've personalized my A constant with the regular True K non-TK, non-total keratometry. So, but what I do is I use the iTrace toric check. So he has the OPD scan because the OPD scan separates the anterior, the corneal, from the internal IOL aberration. I use the same thing, but we just have our own little toys, and I have the iTrace. And if you have the iTrace, you do the toric check post-op, and the toric check will tell you, oh, you can move the IOL 12 degrees, and you will change the astigmatism by 1.12 diopters. So it's worth moving. But if the toric check tells you you can move the IOL 12 degrees, but only change is 0.3 diopters, then there's no sense moving. So it helps you decide if you need to move the axis because my incision might be causing surgically induced change. So my pre-op axis may not be the same as the post-op steepness because of that. And the post-op helps us OPD scan or iTrace because now the post-op image tells you with the contribution of your corneal wound that's healed. So now you have a post-op check to confirm. I think the decision is, do I adjust the axis or am I happy with this axis regardless of the outcome?
But it's what the patient feels, right?
Yes,
If the patient's not
if
complaining,
the
what's
patient's
the
not
difference?
happy, then you have to see, will I benefit from re-rotating? Even if the pre-op Barrett tells me put it at 10 degrees, and I'm at 10 degrees, but the patient's happy and the refractions plus 0.25 minus 1. Then the problem is, do I rotate to make it better? Then we have a machine that tells us rotate or not rotate. If the machine tells us no benefit in rotating. Okay, now it's time to talk about enhancement or glasses, right? But it's a matter of having the toys to guide us in decision making after. Because not everybody is the same, but we try our best to be on target so that we enjoy the patient's outcome.
So, Bobby, do you have astigmatism? Of course. Okay. Would you have this lens? Yeah, of course. So that's great. So an ophthalmologist has this lens. How many ophthalmologists in the room would have the trifocal or trifocal toric lens in their eye? And? Oh, yeah. So he's had it already. But tell us, why did you do that? Did you have a Prozac moment, or?
I had it.
All right.
You know, it's a tough decision.
Can you introduce yourself? Where you are, what you do, and
Yeah, my name is Jose Vargas. I'm based on Saudi Arabia, well, there's another one there where the trifocal. Yeah, so it's a tough decision because your life depends on your eyes. So for me, you know, making the decision to get the surgery was very difficult.
Because you're chicken.
I am. I recognize that I am. I'm 20/20. Well, I was 20/20 with my glasses. But, you know,
what was the refraction? What was the refraction for you?
0.25 Popeye's.
Plus 425? No, what was it before surgery?
+2. +2, yeah.
And you add another plus?
Another plus 2.5. So I want... So I was 24/7, depending on my glasses. So it was a nightmare for the last 17 years. So one day I decided, I have to find a way to get the surgery first without offending my friends. Who is going to do the surgery for me? So I have a lot of friends all over the world, and I say, I have to find a good excuse, and the good excuse is to go on vacation. So I went to see my daughter in Argentina, where there is an excellent surgeon. Yes, no, my friend in Argentina. So that's the first. And second, which is the best IUL for you? And everybody knows that there is no perfect IUL. Even if you look for multifocal IUL, if you look for an EDOF IUL, there is no perfect, or there is no one that fits 100% for anybody. So I have to find out which is the best intraocular lens for me. And the decision was not only based on the technology. I implanted my first fine vision in 2014, many years ago. And it's not only based on the technology, it's based on what you want and what do you need on the surgery. And I want it to be 100% free of glasses. I have the option of wear a monofocal lens. Then I went to EDOF. And then the less of my options was a multifocal because I had a little bit of dry eye. So I did all my tests and I said, okay, I gotta go for EDOF lens. Then when I arrived to Argentina, they run all the tests again for me. And I realized one of the tests was a keratograph. So I told my friend, please let me see the keratograph. That was at 3 o'clock in the afternoon, one day before the surgery. So I saw the keratograph and the result was amazing. So I had no dry eye. But you have to consider that when you live in Saudi Arabia, it is in Riyadh, there is no humidity. It's a very, very nasty condition. A lot of wind, dryness, air conditioning, no rain, no humidity. So you got kind of a degree of dryness. But when I saw the result of the keratograph, I said to my friend, you know what? Call this gentleman there. I'm going to go for the multifocal. I want the fine vision. So I went to the surgery, and my life had changed 100%. I am totally different. In the past, there's any guy from Saudi Arabia here? Anyone? No, good. They don't know how to drive. So my time for driving at night, I will get killed when I get back. So my time for driving at night was very, very, almost nothing, because it's very difficult to drive over there. And, I didn't want to drive. So I said, for me, there's a lot of things about multifocal lenses that people is afraid, like halos, glare,
losses on contrast sensitivity. On the other hand, I want it to be free of glasses. So when you put into a balance what you want, and you say, okay, you have these problems, but also you will win, and you will be 100% free of glasses. That's what you made your decision.
But where are you now with Henoms as well?
I have positive photosis now. I still have halos and glare less than a few days after the surgery in Argentina. When first eye was on May 4, second eye on May 5. I know that they will last for a long time, but it doesn't bother me to drive. After 2 weeks, when I returned to React, I was able to drive. A little bit of insecure, but after 2 or 3 weeks, I was fine. Halos and glare are there, and they will bother you. But by the time goes on, it's decreasing, and it doesn't bother me anymore. They are there. I ignore them. The other thing I had descotomas. I had negative photosis for the first 2 months. Now they are gone. That's gone. But, it's a beautiful experience. I recommend everybody to get it. Well, you already got it as well.
Or Pancho, very quickly. Lovely.
I had my procedure done 3 years ago.
Okay. Do you have halos? Do you have glare?
What's that?
Oh,
What do you mean about that?
okay. Sorry, I asked a stupid question.
No, yeah, I just like Jose, I was very tired about wearing glasses, and I do multifocals for the last 20 years. I have done all the brands all around, and definitely for me, I think Calculator, for example, there are some companies that Calculator is not good enough. There's a brand in Germany, and you don't have any chart calculator. So I had the procedure 3 years ago. I decided to go for Phaco, and they decide the magnitude and the axis with the aura, and I'm very pleased. I went to my follow-up, 3 years follow-up last month, and I'm 2015 distant, 2020 intermediate, 2015 year for that reason. And I went to the surgeon and I didn't ask anything. Do whatever you do. If you decide to go for -1/4 on the left, it's -1/4 3 years after. And I'm planner of the right. So I'm planner for -1/4. So I'm very pleased with the results. I really recommend it. And definitely, acrylic hydrophilic is the way, because quality of color vision, longitudinal aberration, the color vision definitely is much, much better with acrylic hydrophilic compared with acrylic anthropic. So that's why I decided, and they check me with this new software with the Pentacam to check if you have PCO. I don't have PCO at all 2 years after. So my wife is there. She's an ophthalmologist too. I operated her on 6 years ago. And she's 20 all distances. So definitely this is the best option, I think.
Very good. Give him a hand. Thank you, Jose and Pancho. Now how many of you will have wide vision lenses in your eyes? Never mind. I'm going to move on now. Thank you very much for those contributions and for those questions. We're now going to move on to another very, very interesting lens. And this is the Isopure. And my friend Ahmed Asaf from Egypt is going to talk about an Egyptian condition and Isopure. Welcome, Ahmed.
Thank you very much. I love being here. And I have a strange feeling that it's the first time for me to have a presentation, an open-air presentation like this. Thank you, Amanda, for orchestrating this meeting. Where is Amanda? Here. Isn't there any snacks for the speakers? Because I see snacks everywhere, but not for the speakers. Okay. So I'm going to talk to you about my experience with the Isopure lens, with the kind of EDOF lens or isofocal lens like BBI mentioned. And as you know, its relation with the angle kappa and angle alpha. And there are several reports. It's a matter of debate, by the way, that the angle kappa might influence the visual outcomes for some presbyopia correcting lenses, while other reports deny any correlation between the angle kappa and the visual outcomes of those lenses, presbyopia correcting lenses. probably this debate arises from the different designs of the presbyopia correcting lenses, the innermost diffractive ring, and of course the angle kappa found to be significantly less after implantation of the lens. And it was reported that the angle alpha is staying stationary, but the angle kappa is significantly less compared to the preoperative value. It was suggested that the light rays with the large angle kappa might hit the edge of the innermost ring of the diffractive optic on the optical part of the lens, and this might cause some glare and halos after implantation of the lens, especially in eyes with the functional decentration caused by angle alpha and angle kappa. There are some, Shiraz, where are you going? Yeah, there are some renowned surgeons worldwide deny any correlation between the visual outcomes as well as the angle kappa, and mention that it's related to Egyptian thing, ancient Egyptian thing. And probably I was searching for this in the temple of the ancient Egyptians, probably in the Karnak temple, and you can see probably this is an angle kappa. This is the drawing or sculptures depicts an angle kappa, which is an ancient Egyptian thing. So probably you are right. Okay. So as you know, that angle kappa is the angle between the imaginary line, which is the pupillary line, which is then a imaginary line between the line perpendicular in the center of the pupil and the visual axis, while the angle alpha is the angle between the visual axis and the optical axis. Usually, they are quite close to each other, but usually the angle kappa is less compared to the angle alpha. And it's measured by the distance of the chord lens between the visual Purkinje first reflex and the center of the pupil. You cannot measure it in angle except by the synaptophore, but you can measure it with the aberrometer, with the topographer, with the IOL master, but in a chord lens, which is the distance between the Purkinje reflex and the center of the pupil, which is the angle kappa in particular, and it's measured in microns or millimeters. So as you can see here in this graph. So the purpose of our design, we constructed a prospective non-randomized study to compare, to assess the visual outcomes of the angle kappa and alpha on the visual outcomes after implantation of the IsoPure lens. It's a non-randomized study, prospective inclusion. We included eyes with for patients above the age of 45 years old coming for cataract refractive surgery or refractive lens exchange with corneal astigmatism less than 1 diopter, and we included 66 eyes for bilateral implantation of 33 subjects with bilateral implantation. We measured the angle kappa and angle alpha with eye trace, and for those people who are not acquainted with the eye trace, it can measure the angle alpha and angle kappa. And to ensure the consistency of the measure, we took 5 measurements, 5 captures every time, and by expert investigator, we took the best 3 captures, which are not different more than 0.25 in terms of K readings or the axis less than 10 degrees. And this was selected, 3 captures was averaged by the eye trace software, and this average was registered for the study. So as you can see here, after implantation of the IsoPure lens, most of our eyes had spherical equivalent of pretty close to emmetropia, slightly toward the myopic side. None of the eyes had refractive astigmatism more than 0.75 diopters of refractive astigmatism. And you can see here the visual acuity. Most of the eyes had uncorrected and corrected distant visual acuity of 25 on Snellen's chart. And you can see that the uncorrected distant visual acuity of the logMAR value is pretty close to emmetropia together with the corrected distant visual acuity. And here you can see this is the distribution of the angle kappa and angle alpha. Angle kappa in green and angle alpha in blue. And you can see here, it's quite interesting that the angle alpha is consistent along or distributed along the 180 degrees. And the angle kappa has different values regarding the axis. It has been reported before. It was quite striking to see that the angle alpha is consistent. And by the way, when we compare the angle alpha pre-op and the angle alpha post-op, we found it's almost consistent without significant difference, but we had a statistical significant difference, less angle kappa post-operatively compared to the pre-operative value. Anyhow, the postoperative angle kappa was measured, postoperative angle kappa was 0.39 millimeter, and the angle alpha postoperatively was 0.45. We included eyes with pretty low angle kappa or alpha, and we include eyes with a very large angle kappa up to 0.74 and angle alpha up to 0.74 of chord length. So what about the correlation? We couldn't find any correlation between those angle kappa and corrected distance visual acuity, and you can see there is no effect, and eyes with large visual angle kappa still can enjoy corrected distance visual acuity, quite similar to those eyes with the low or small angle kappa and alpha. And you can see we measured as well the total higher order abrasion of the eye, and we focus on the higher order abrasions, spherical abrasions, trefoil and coma, and we find all the abrasions are within the normal compared to the normal values, whether the angle kappa is large or angle kappa is low, and the same applies for the angle alpha. And here you can see that we couldn't find, again, we thought that there is induction of the aberrations by eyes with large angle kappa or alpha. We couldn't find any correlation between, or weak correlation between the corrected visual acuity and the higher order aberrations as well. So eyes with a slightly larger, higher order aberrations still can enjoy excellent corrected distance visual acuity and quality of vision. And we couldn't find any correlation between the intermediate visual acuity and the angle kappa and angle alpha. As you can see, those eyes with large angle kappa and angle alpha still can enjoy functional vision at intermediate distance at 80 centimeters. And you can see here, this is the modulation transfer function, the mean modulation transfer function for all eyes, and this is an example for the modulation transfer function for one of the patients after implantation of the IsoPure lens. And for those people, again, who is not acquainted with the iTrace, if you find the total eye modulation transfer function above this red rectangular, that means that the patient can enjoy excellent quality of vision. As long as this yellow line hits the red rectangle, that means that the quality of vision is not optimum. So as you can see here, the patient with the total modulation transfer function is quite high, and the patient can enjoy excellent quality of vision even after implantation of an EDOF lens with a large angle kappa. Why is that? Why there is no correlation between the angle kappa or alpha and the visual outcomes with the IsoPure lens? Probably, if we just have a look on the eye, you can see that the lens is, we don't have to forget that the lens is quite thinner compared to the crystalline lens. So the lens sits opposite to the posterior capsule, quite close to the nodal point. So this is one assumption. The other, that the polynomial technologies, which is responsible for the extension of the depth of focus of this lens, is distributed on the anterior as well as on the posterior surface of the lens. Again, it's quite close to the nodal point. So the functional decentration caused by large angle kappa or alpha might have less influence on this lens because the lens is very close to the angle, to the nodal point. And again, the polynomial technologies is not only on the anterior surface, but it's distributed on the anterior and posterior surface. And this lens has no zones compared to the other EDOF lens, which has a central element, might affect the visual outcomes with the decentration of the lens within the capsular bag. So let me show you some case studies showcasing. This is the 57 years old lady, and she has a nuclear 1 cataract and nuclear 2 in the other eye, interested in spectacle independence, coming for cataract surgery, and she does a lot of night driving. And you can see you have a large, on the OPD, you have a large angle alpha here on the right side, as well as on the left side. You can see the pupil is slightly shifted on either side, on the temporal side. And here, you can see here again with the iTrace, after implantation of this lens, still the patient has large angle alpha 0.6 in the chord lens. But again, this is the dysfunction lens index. That means that the patient enjoy excellent quality of vision, 10 out of 10 on the dysfunction lens index score. And this is the visual outcome, the higher order aberrations of after implantation of this lens. And again, you can see the modulation transfer function away above from the above the red rectangle or the red zone for bad visual quality. Another patient, 63 years old, he was a personality type A, nuclear to catch up, and he's interested in spectral independence for distance and near. And this patient, every time steps inside my office, has 4 papers like this, A4 papers, with full of questions asking about every visual dysphotopsis before and after the surgery, every step of the surgery. And one of those questions that I cannot see the color of my neighbor across the street. So he was very meticulous. And after implantation, because this patient was interested in spectral independence for distance and near, I couldn't dare to implant a trifocal lens. So I just implanted an EDOF lens for this patient, and this patient again was pretty happy after the visual outcomes. And you can see here, this is again the angle kappa and alpha. It's not low, 0.5. And sorry. And you can see here, this is the modulation transfer function. And again, this is the visual, the higher order aberrations, quite low, although we have 0.5 millimeters of angle kappa or angle alpha. So again, my conclusion that angle kappa and alpha has no significant influence on the visual outcomes after isofocal lens implantation. The optic design of this lens makes it more robust for the functional decentration caused by large angle kappa and angle alpha, but still the angle kappa or alpha is not an Egyptian thing. Are we still friends?
Okay. So,
Yes, still friends?
so the angle alpha is fake news, right? And alpha kappa is calculations. Oh, thank you very much. That's very good. I think it illustrated extremely well in a scientific fashion. And it's interesting how things have changed. So thank you very much.
Thank you. Thank
so
you.
the last but not least and the most important is Dr. Orts from Alicante, who's also here to speak about the Isopure lens. She was the clinical investigator for the principal clinical investigator for a large multicentric study. Welcome.
Thank you. Thank you, everyone, for coming. Okay, thank you also, Bibi, for the kind invitation. I'm very pleased to be here and share our experience with the Isopure lens. I will not go into the technical details, as Dr. Asaf has already mentioned them wonderfully. You may know that there are several in vitro studies and also quite a few clinical studies. And we may have time at the end to discuss the differences between the result of all of them, but I can tell you that in general, they are very similar, and well, we will focus in this paper here, which was published in Barts this year, and in which we participated. As you can see, it has the most larger number of patients, 183. And these are the points that we'll be covering. We will discuss the endpoints of the study and then briefly the results. This study was conducted in 6 different centers in Spain, and the primary endpoint was to show that the monocular corrected distance visual acuity was non-inferior to the outcomes of the monofocal parent lens MicroPro. The secondary endpoints were to assess the visual acuities for far, intermediate, and near vision, as well as the defocus curve, the contrast sensitivity, and the patient satisfaction through some. Okay, for this purpose, we included 183 patients, of 109 patients. And here you have the results for the spherical equivalent. They are not as good as Dr. Asap one I've seen, but I think it's because maybe it's a larger sample of patients and they may be more myopic or hyperopic patients, but still it was very good. 45% of the patients were within 0.25 diopters, followed by a large group of 18% of the patients within 0.2 and 0.5 diopters. The mean postoperative spherical equivalent was minus 0.12. And here you have the results for the distance corrected vision for monocular and binocular conditions. Oh, sorry. I'm sorry. Okay. I'll see here. Okay, as you can see, 94% of the patients could see 20/25, and 87% of the patients were able to see 20/20. For uncorrected visions, the results were equally good. As you can see, 80% of the patients were able to see 20/25, and for binocular conditions, this percentage increased to 90%. Those are the results for the corrected vision. As you can see, for monocular, it was 0.06, and for corrected vision monocular was 0.01. It always in logMAR scales. And here you have the results for the intermediate vision, which was especially important to us. And as you can see, it was taken at two different distances, at 80 centimeters and 66 centimeters. Oh, sorry. And 80% of the patients were able to see 20/25 or 80 centimeters, and 50% were able to see 20/25 at 66 centimeters. Here you have the results in logMAR scale. It was 0.04 for 80 centimeters and 0.13 for 66 centimeters. And well, we all know this is not a lens designed to be able to read without glasses, but yet more than 40% of the patients were able to read 20/40 at 40 centimeters. And just to finish with the results, let's have a look to the defocus curve. As you can see, there's a peak of excellent vision, a bit above 20/20 for 0.0 version, and a smooth reduction of the visual acuity with increasing negative values of the versions. And as you can see, there's a very, very good vision for 100 centimeters and also a good vision for 67 centimeters. Our results were quite similar to the ones, or even slightly better, of the ones obtained by Bova and Vita. And just to show that our results are in agreement with other authors, you can see that all the curves seem the same, and generally, it offers a good range of vision. So we have included a large number of patients to provide further evidence, and we can state that the Isopure provides excellent far vision and a functional intermediate vision. It has so showed a good accuracy in the postoperative refractive error, and therefore, I think it should be considered an excellent option when we want to correct aphakia and give our patients intermediate vision, functional for the computers, for makeup, for many, many tasks that we nowadays need the intermediate vision. And that's all. Thank you.
Great, thank you very much. So what you've basically described is a lens that's been labeled a monofocal plus, but that's not true. It's actually an increased range, or at least an EDOF by the ANSI standard. 50% have to see 0.3 logMAR at 67 centimeters. And you've demonstrated that. I think you were 50% on the mark, right? Or no, that was 2025. So
50% was for 0.5 for 40 centimeters.
Okay.
For near vision.
For near. But you also showed, so you showed 2025 was present in 50% of patients in the intermediate. Well, anyway, it beat the ANSI standard, right? So technically, it's an EDOF by the ANSI standard lens or an increased range of focus lens.
What is the target of refraction after this implantation of this lens? What is your
The target was also zero.
Zero.
For the study. Okay, in my general practice, I aim at minus 0.5 in non-dominant eye. If the patient is concerned about the near vision, I try.
This was my next second question for you, because if we can target minus 0.5 representing the non-dominant eye, the patient is quite happy having the near vision as well.
Normally they are happy, yeah.
Thank you.
But for the purpose, I aim zero.
So that's Dr. Albarkat from Jordan wants to ask you a question.
Actually, I'm going to ask to all of you. Thank you for the presentations. I want to ask if anywhere one of you just mixed and matched the Isopure and the Fine Vision? Let's say you implanted the Fine Vision and something went not very well and the patient was not very happy.
Nancy, you're like a complicated life.
Come on. It happens.
Okay. Is that what you do? Do you do this?
I had to.
I have no experience with that. And I find maybe I'm an impatient doctor. I don't have time to talk to patients about the shots. Okay, Ed, have you done that? Mix and match a Fine Vision one eye and an Isopure in the other?
I did the but with other lenses, with the trifocal lens for other brand, and the patient was not happy, so I had to implant a monofocal lens and the other monofocal
Plus.
Yes. And it solved the problem, but still the patient complaining with the monofocal plus they cannot read.
They read.
This is a monofocal. Yeah.
So you won't do that again? Okay.
Yeah, well, for me, it's a rescue strategy more than an intended strategy.
Yeah.
So we don't intentionally want to put different lenses, but I've had the experience of putting a trifocal, even if they're on target. Sometimes they feel that the far vision's not enough, that you cannot put the same trifocal. They will say, but I'm already not happy with the far. So you have to save the far vision, and you want a little bit of depth. So you probably want an Isopure rather than a pure monofocal. On the other hand, we've also had the monofocal, and then they were saving money, and then after 1 year, now they have money and they want something for near in the other eye. So you are given a choice of classic monovision, an EDOF, or one that is surely going to give you a trifocal. So these are like not unintended strategy, but it helps us because now if they do this, they got what they want. They have one for far and one for near, which is they can complain because that's what we gave them.
Yeah,
But
absolutely. Thank you. And but let me just ask this: is it cumulative, the halos and glares? If you put a trifocal in one eye and you put an Isopure in the other eye, would the halos and glare be less than if you put trifocal in both eyes? Because usually they're not happy because they're of the halos and glares. And
Yeah, but in the majority of cases, as you hear from our ophthalmologists who had the surgery done, it all goes away in time anyway. So at what point are you measuring? And I think that's
at a pretty difficult stuff.
yeah. Oh, okay.
So sometimes you have to. It's a risky situation, as obviously.
So
Yeah, go ahead.
what about the Isopure in laser-based presbyopic treatment?
Laser-based presbyopic patient.
Yes. So we are creating negative spherical abrasion, whatever the model of the laser base, because you will interfere. I know, Shiraz, that that different than whatever the model. It's a negative spherical abrasion. Whether we are adding 2 in one eye in the non-dominant and 1 in the other eye, which is the dominant, and then what we are doing. So we are running a study. In that eye, in those both, we put the Isopure. Isopure, it's when we define the power of the Isopure with the company, they are all here. There's no exact power because it depends on the power of the lens. So the higher, the lower, the lower. So from this point of view, the higher means that the higher power of the lens, the higher negative spherical abrasion. At the end, it's a negative spherical abrasion. So if we could calculate the centration of the laser base, in a way that it shows that the patient happy in the beginning, then start to be not happy, and we implant Isopure in it. So the eye that has 2 ads, he has 2.75 consuming, and the eye that has 1, he end up with 1.75 after implanting of Isopure. So the patient was very happy with the distance and near, and he didn't have any halos. We know that the negative spherical abrasion of the corneal base, it will not create halos.
And that is a good option. I mean, there are many ways to handle all this, and you've gone through a very intellectual exercise in dealing with how the patient might or might not behave. But what you have to remember is a average pupil size, as demonstrated by Joaquin Fernandez and others, more than 85% have a pupil less than 4 millimeters post-lens removal. The aberrations, the spherical aberration that you correctly point out that's present at 6 millimeters does not exist at 4 millimeters. So are we treating ourselves or are we treating the patient?
No, see, here we need to discuss it in a different way. Because you said that the pupil, what do you expect that the pupil post certificate?
I'm saying.
What's the minimum?
What I'm saying.
Minimum.
So no.
In an area of JCC, let us say, that where the sunlight is 360, it's not less than 2.5. That's measured and studied. So it's, let us say 2.4. What our treatment for a laser base? Is a 2.4. See?
No. I think we can get to the study. We'll talk about this afterwards.
And let me
The thing is,
share.
the worry is the influence of aberrations. The influence of aberrations is significant when the pupil is big, rather than when the pupil is small. And that's
Let me share my experience, because I have already implanted this lens in post-hyperopic and post-myopic laser vision correction. So it's quite challenging for the post-hyperopic because of the centration, because of the negative induction of the negative spherical aberration of the cornea level, as you mentioned. But let's remember that with the hyperopic LASIK, even with the presbyopic LASIK, we are inducing negative spherical aberration, but the corneal spherical aberration is never toward the negative side. It's still pretty close to zero, but it's not overcrossed to the negative side. It's, yeah.
You can measure even code. Suddenly it happened. You can measure the negative spherical aberration.
On 6 millimeters, but as Shiraz mentioned, yeah.
it is, no, 6 millimeters is the ANSI standard. But you're not measuring, you're measuring something theoretical, but in reality, the patient is looking through a 4 millimeter pupil or less.
But because of the regression and because of the epithelial hyperplasia, the spherical aberration of the cornea sometimes is just pretty close to zero. It's not negative as we thought. It's just close to zero. The normal corneal spherical aberration is positive 0.27. But with the presbyopic LASIK, it's just moving toward the negative side, but still the positive side. So
our mouth or the highlighter.
Yeah. Yeah. What I would like to say, you have to select the patient before. Yeah, okay. So if the corneal spherical aberration is close to zero, it's better not to implant this highly negative spheric lens. If the corneal spherical aberration is 0.1 or slightly larger, so you are in the safe side, you can implant this ISOPure lens and the patient can enjoy reading and intermediate vision as well as good quality vision for distance. This is my experience.
Okay. One last question.
Yeah, I'm going to kind of continue to Dr. Safwan's issue, but I'm going to relate. If you have a patient that's +2, undergoing phaco, it's pretty straightforward. But if you have a patient, and we see them a lot in the GCC in Dubai, if you have a patient like Dr. Asaf is saying post-LASIK, and what it's worse, post-RK, which we have tons and tons and tons of patients in Dubai, would you go for an enhanced monofocal? Would you go for an EDOF? Would you go for a trifocal? If, say, there's no cylinder, there's no cylinder there, so let's say it's only a hypro.
So we're just reviewing 600 eyes who've had defective lenses post-LASIK, both myopic, post-myopic LASIK, and post-hyperopic LASIK. And the results are actually remarkable. But these are...
And you aim for plano?
That's a bit more detailed. But the calculation is the hardest bit in these patients. It depends on the profile of the cornea and so on. That's a whole topic for another day. But I use trifocals in these patients. And I find it very, very good. Patients find it very acceptable. They're going to be the outliers. Our enhancement rate is less than 6%.
And I have one other question to Dr. Asaf. He spoke about the Anga kappa. Do you tend to center your IOL and all your patients in the same manner, or do you kind of shift them a little bit depending if the patient has Anga kappa?
Yeah, this is a very good question, because we learned from the past that we can just shift the lens to the either side, to the nasal side or the temporal side. But to be honest, the lens will stay where the capsular bag anatomy control the centration of the lens. You can get a pretty good centration of this kind of 4 haptic lens, whether it's closed loop haptics or open loop haptics lens. But if you just nudge the lens to one side, you'll find it, and then the very next post-operative day, it's another side.
You're treating yourself.
Yeah.
Yeah.
Okay, well, I'd like to thank BDI for inviting us to speak. I'd like to thank the speakers. They were all excellent presentations, nice and scientific. And I wish you all a great meeting, and thank you very much for attending.